Masterclass. Today we're going to talk about priority setting in global health and balancing the economics, ethics, and feasibility. And today I'm very happy to introduce two new speakers to you all. First of them is Rob Baltussen. He is a professor of global health economics at Radboud UMC in the Netherlands, in Nijmegen. And there he leads the IQ Healthcare Group on global health priorities. And his research focuses on developing and applying evidence-informed deliberative processes to design fair, transparent, and sustainable health benefit packages, supporting countries in achieving universal healthcare coverage. And he has advised ministries of health and international organizations such as the WHO and the World Bank across Africa, Asia, and Europe. And Rob combines methodological innovation with hands-on policy engagement, aiming to strengthen health systems through participatory decision-making and better use of scarce resources. Then our second speaker today there he is Gavin Sergi. He is a senior researcher from South Africa in health economics, also working at the Radboud UMC in Nijmegen. And his work mainly focuses on evidence-informed priority setting for university health coverage, with a particular experience in designing and revising health
Ja,
benefit
is echt zo lief.
Sorry, someone is unmuted. Manu, could you look at that? He has particular experience in designing and revising health benefit packages in low and middle income countries. Kevin has led projects in Central Asia, Sub-Saharan Africa, and South Asia, supporting Ministry of Health to strengthen transparent and participatory decision making. In Kyrgyzstan, he coordinated the recent revision of national health benefit package, working closely with national stakeholders and international partners. His research combines methodological development with practical application to inform fair and sustainable health policy. Before I hand the floor to our guests, I would like to inform you that today's session will be recorded as usual and will be found at our digital learning environment of KCGH. If there is any problem, because we know there were any problems or some problems over the past few weeks with accessing the recordings, please send us an email so we can help you out. And the questions can be asked either in the chat or during the session. I will keep an eye out as a moderator and see. At the end, we will have some time for the discussion. All right, then I would love to give the floor to Rob to start our presentation.
Thank you. Thank you, Alzeline, and welcome to all of you. When I listened to Alzeline and her introduction, I thought, oh, that's complicated. Of course, we gave the text to Alzeline to introduce us, but in the next hour, Gavin and I would like to tell a very simple story about what health economists do and why it's important, and also how could you use this in your work, possibly. So we like to stay away from difficult concepts, difficult terminology, and keep it all understandable also for you. Like, I think most of you have a medical background, and so let's see how we can best do it. The title of this talk is also a bit abstract, a bit complicated maybe. Priority setting in global health, balancing economics, ethics, feasibility, and politics. And I can maybe best explain it with the figure that you see on the right-hand side. You see a pie and different people wanting to have a different slide of the pie. So the pie you can see as the entire health budget in a country, and the different hands represent different people with different needs. For example, a patient with tuberculosis likes to have access to tuberculosis treatment. A person with a mental health problem like to have counseling services. On the other hand, can represent a pregnant woman who like to have an assisted delivery. Or on the other hand, again, could be a person suffering from cancer and he likes to have access to expensive medication. So everybody likes to have a piece of the pie, and priority setting is actually about who gets what in healthcare. So how is the money, all the money that's available with the government and healthcare, how is that being distributed? How is that being handled? And who's basically deciding where the money goes? So that the economics come in when you think about the value of different services. When you talk about the tuberculosis treatment or the assisted deliveries, or if you think about the expensive medication for the cancer patient, economists like to think, what is the value of that service in terms of, does it improve quality of life? Does it extend the length of life? And how much does it cost? So that's where the economics come in. The ethics come in terms of who is deserving healthcare more than other people. For example, are the young people deserving healthcare more than the old people? So would you rather spend your money on services for young people over other people, or healthy or relatively severe diseases compared to non-severe diseases, or the rich compared to the poor? So it's about who deserves what. The feasibility is about, if you like to implement a program, can you really do it? For example, you may think a breast cancer screening program would be really valuable in a country, but is it also feasible? Because it takes quite some logistics to organize it. And politics is always coming into play. It's about how different groups are being organized. For example, patient groups. Cancer patient groups are typically well organized, so they may put pressure on the Minister of Health to spend more money on cancer services so they can get a bigger piece of the pie. So the picture on the right-hand side is basically reflecting the title, Priority Setting in Global Health. It's about who gets what in healthcare. So this lecture tells you about the process, how these decisions are being made. So you get a better understanding of are some services getting more and better funding than other services. The thing about priority setting is not only relevant in low middle income countries. Those who live in the Netherlands among you may have seen the recent debates for the elections. A lot of debate about the benefit package, the basispakket. Should new services still come into the basispakket or not? So that's the same discussion. It's also about different diseases, different services, different patient groups, putting pressure on the Ministry of Health to get funding. So this is an interactive slide, and I'd like you to think with me on services that you would prioritize. Imagine you're a policymaker in an imaginary middle-income country, and there is a budget constraint. There is not enough money to do everything for everybody, and you need to choose between three cases. And if you choose for case one, everybody in the country gets that service. Case two, that's a bit early. There's a poll coming in.
Yeah.
Sorry?
Okay.
Yeah, so if you move that. So we have three cases. First case is Alia. She's a newborn, and it's provision of an intensive care unit. So 750 babies would need this intensive care unit. The cost of one unit is 1,700 euro per person, and the total cost is 750 times 1,700 euro is around 1.27 million euros per year. All right, so that's option one. Option two is to provide treatment for tuberculosis for Nestor, 33 years old. Many more people, compared to the intensive care unit, need the service, 450,000. The costs are quite low, around €3. And if you multiply this, the budget impact, the total cost amount to €1.2 million per year. Then there's a third option. Christine, 62 years, suffers from moderate hearing loss, and the case involves the provision of hearing aids. 10,000 people suffer from the hearing loss. The hearing aid is costing €125. So here the 10,000 times the 125 makes up a total of €1.25 million per year. So the question to you is, where would you spend your limited money on? And if you choose Alia, all babies in the country receive the intensive care unit, and the same goes for Nestor and for Christine. So we then turn to the poll, and I think you have it on your screen. I see votes for Nestor, vote for Christine, few votes for Alia. We have 59 people in the lecture, and we already have some 40 replies. And we see there is a preference for treatment to Nestor, followed by Alia, and followed by Christine. So in the next question in this session, I'm going to ask you, why do the people who voted Alia, why did you vote for Alia? So I stop sharing. We see that most voted for Nestor, then Alia, and then Christine. So the next question, and I think Manouk, you can help me in this to put up question number 2.
Yes, I just did it, but it's going back to question 1 now, so it's strange. So give me 1 second.
Okay.
Launch again. Yes.
Yes. So people who replied that Alia would be the preference, can you give me your reasons? So you can type in your replies. And I think,
Or just mention it.
or mention it, indeed. That may be easier. Please shout out. Anyone wants to speak out? I see some 4 replies. I do not see them yet on the screen. Manouk, maybe you can show them on the screen.
Yes, as I said, I have to end the poll in order to show the results. So
Okay.
then maybe we can wait.
Oh, but that's fine. That's
yeah?
fine.
All right.
That's
Then I'll
fine. We've
end
got
the
6
poll.
replies.
Share results. But they don't show up. Here they do. Aha. 1 second. Then I just have to overrule your your screen sharing for a second. Rob,
Yes,
is it
that's
okay?
fine. That's
All
fine.
right. Perfect.
So the other people who voted for Nestor, that's the next question coming up. You can already think why you voted for Nestor. And what we typically see is that people have different reasons to vote for certain cases. And
Well, I don't mind sharing why I voted for Aya.
yes, please. Yes.
I have to say I had 2 reasons for voting for Aya. One was it has a benefit across the life cycle of the.
Please say that again.
Sorry, what did you hear?
I had some other people in the background as well.
Okay.
So can you repeat?
I had 2 reasons for voting for Aya. One is because it has a benefit across the whole life if you start from a premature baby. And the other reason was because you mentioned that many people were voting for Nestor. I thought, yeah, then I also want to achieve sort of health equity. But it is based on a feeling then, to be honest.
Okay, thank you. It's nice to hear your reasons, or how we put them typically is decision criteria. And countries use decision criteria to make these decisions. And people say indeed, sometimes there's a preference to target young people, especially babies. People say they have more benefits over the lifespan, like you say, but also they are more vulnerable than, for example, adults. So this is what we often see in countries that actually develop priorities. And Gavin, in the second half of this lecture, will show you what the decisions or what the criteria are in Kyrgyzstan, the country we work in. So what policymakers have been using in that context. So let me see. Most years gained, child mortality is a key indicator of a strong health system, future workforce. Indeed, these are all different reasons that people may use to vote for Alia. So briefly, people voting for Nestor. Can you give me your reasons?
All right, I don't know if I can speak on Bismarck.
Yes, please.
Well, I voted for Nestor because looking at the TB is actually infectious disease that can spread, and it can spread to affect everyone if we're not taking care of it. And if it affects everyone by spreading, that means that the population of the country is going to be down, and the age bracket is 33. That has to do with the young population, which have to go to work to ensure development, economic development, social development, every development of the country. So if we get that population down with TB, then means that the country will not survive to take care of the kids and other older population that is 62 years and the zero. So priority, in my view, will be set on that 33-year bracket, age bracket, and also to deal with the infectious disease that can spread faster to affect the population. Thank you.
Thank you. That's a nice answer. Indeed, work population and the spread of disease can be important considerations. Manu, can I ask you to show the results? Just to see what other people have.
Yes, I'm coming
Right.
up. Just 1 second because I have to share the results in a different way again.
Okay.
So I have to again share my screen. Here we go.
Thank you. So people say the qualities or the health benefits is a contagious disease. That's the same as the previous speaker said. Most people reach cost benefit analysis is positive. So this is more leaning towards the health gains. Then I also see, productivity cheap. So if you put this in the context of the title of this talk, it's about economics. It's about what's the value of services, which service is producing most health. So here we see that people vote for Nestor because it's producing more health than maybe the intensive care units for the premature baby. Then ethics comes into play because people say when it's about young people, maybe they deserve it more than older people. And then also feasibility and politics, that always comes into play, maybe not in those replies, but that these are often consideration, and also Gavin will talk about those dimensions. If I can go back to my screen.
Rob, I see Shruti, if I pronounce the name right, of her, has a question for you.
Okay.
It's not a question. I was just trying to bring my perspective into why I voted for Nestor as well, is because TB is also a disease of poverty a lot of the time. So, it also affects vulnerable communities like disproportionately. So I feel like there also comes a sense of health equity perspective in place as well.
Yeah, indeed. And well, the interesting thing is already in this session, you see different people voting for different services. So you can imagine at the political level where these decisions have to be made, you've got the pressures from different patient groups on the Ministry of Health to advocate for funding for their services. And the work we do is to support ministries in making those decisions. And on the one hand, we bring in the evidence. We bring in the evidence on the cost, on the health effects of, for example, these three interventions. Plus, we organize discussions with the patient groups so everybody can have its say and can basically advocate for their own service and provide the argumentation. So to take one step back after this introduction, what is priority setting in global health? Like I said, policymakers are facing difficult choices in healthcare. Countries have limited spending. In the Netherlands, we spent around 6,000 to 7,000 euro per person per year. In a country like Rwanda, where I'm working these years, it's between 30 and 50 euro or dollar per person per year. So the budget is much smaller than we're used to in the Netherlands, but also the challenges are much bigger in terms of health needs. And the health needs are almost infinite in the Netherlands, but also in a country like Rwanda. So there is a need to prioritize where to spend the money. Like I said, it's true in the Netherlands, but especially true in low-income countries because the spending is often extremely limited, especially with the recent cuts, for example, on USAID, on the foreign assistance. So countries really need to think where to spend the money and if they need to reduce the health expenditure, what to cut, or can they find other ways to raise health revenues? A health benefit package, and that's not often considered by many people, is really important, I think. It's a beating heart of the health system, and it's really where the money is being distributed, where the prioritization takes place. It's about deciding which services will receive public funding. And the next sentence is basically the key sentence of this lecture, and I think that's really important for you to try to understand. So if you see in your work in the field, whether it's in Malawi or Mozambique or Kyrgyzstan, if you see that services are underfunded, there is not enough money to buy the equipment, there is not enough money to pay salaries for health personnel, the root problem is often with the health benefit package, because the health benefit package in many countries is not well organized. It includes many, many services. It's basically an aspirational list that includes many services which are not well costed and which are not practical to implement because there is not funding available to implement all services. So if you have a long list of services, which is on the one hand good, but you don't have the money to implement them, the result is low quality healthcare. And that's what you see, or what you're going to see, I think, in your work. You see shortage of funding, and the root problem is, I think, trying to do too many things in the health benefit package. On the right-hand side, you see this visualized in a cartoon. You see a minister of health with a long list of services, and it says health priorities. And that long list is basically the benefit package in a country. And the minister is scratching his head, like, I don't know what to do with it because I don't have the money. These are all the wishes, but I don't have the money to implement everything. And then on the right-hand side is a lady with scissors asking, can I help you? And this could be any consultant or researcher or staff in a ministry that is supporting policymakers with seeing what is best evidence and seeing what's best value for money. We call this health technology assessment professionals. So people who assess the different technologies in healthcare and who provide advice to ministries of health on the definition of the benefit package. So good practice is, then we are on the left-hand side, is an explicit health benefit package. So it's very clear which services are included in the package, and included services are also affordable. And it's only a few countries in the world that have a very, very clear benefit package. National Health Services in the UK, Norway, Sweden. I think in the Netherlands we do quite well in terms of definition of the benefit package. But many other countries have to various degrees an implicit health benefit package. And that's basically the long list that you see in a cartoon. So services are not well defined, which means that patients don't know to which services they are entitled. They come to a health clinic and they may want to have some obstetric services, but they're not entitled to it. So they don't have the right to have the treatment because it's not well defined whether they should have the right. And like I said, it's often a long wish list and there's not enough funding to implement the services. So often the services and the equipment are not available at the point of use. So the core message that people like me and Gavin in South Africa is ventilating when he is at the Ministry of Health is, don't try to do everything for everybody. Try to reduce the things you like to do and do that well. So see what's affordable, reduce your package, and make sure you have enough funding for these services. So then you can offer them at high quality, right? So it's not rocket science. And like I said in the beginning, we can make things very complicated, as in the introduction, the bios. But basically, it comes down to how much money do you have on the one hand side, and what do you want to do with it on the other hand? And these two should match. So a benefit package is not a static thing. It needs regular revision. So we did a survey among countries. What did you think about the benefit package? And some people say, well, we don't have the financial resources. So that's the key, the root cause that I just mentioned. We do not have enough human resources and infrastructure, too many high cost interventions. So there's lots of things to think about in when designing the package. I'm looking at the time. We're at 12:30, and I'm also looking at the question. One question is, when you hear the term universal health coverage, what comes to mind first? Access, affordability, or quality? Well, and we are nicely put, we are at the slide on universal health coverage. Let me first explain the slide and come back to the question, and then I hand over to Gavin. So the slide is about using the benefit package to reach universal health coverage. And universal health coverage means all people receive quality health services in need without being exposed to financial hardship. And in the figure, you see the universal health coverage cube, which is very often used in the global literature. And it has 3 dimensions. You may have come across it. It's about who is covered with healthcare, which services are covered, and what proportion of the cost of services are being covered. And the blue box in the middle is basically reflecting the available funding. So a country has a choice with the benefit package to maybe provide more services or provide fewer services, but then extend coverage for those people who need it very much for essential services, or they may want to improve access by reducing this access, reducing the proportion of cost that people pay. So it's in a benefit package, it's moving between the 3 axes. That's a bit technical language, I know, but to respond to the question, I think coverage is essential. I think it's really better for a country to limit the number of services they want to provide, so to reduce that long list of services, and then to provide this reduced list of services to as many as people as possible. So it's an absolute priority to first provide essential services to everybody rather than introducing new services which are less valuable. Here I stop. I'm going to skip some. No, leave it there. Yeah, okay. And I'm going to hand over to Gavin.
So hi, everyone. I'm going to start off with a quick question of how much do you think the Netherlands spends per person on health benefits each year? I'm in the Netherlands, Rob's in the Netherlands. Some of you are, some of you aren't. Maybe you can think about that now and we'll come back to that. And we'll put it into perspective later in terms of the challenges that we have to face in setting priorities. But I'm going to turn now to the very real life example, is because it's what is taking place, and that is revising the health benefits package in Kyrgyzstan, and there they call it the Standard Guaranteed Benefits Package, or SGBP. So you might hear me saying that quite often. And I'm just going to talk through some of the methods we followed to get to developing the SGBP. Those are the results of the SGBP, and then finally end off on the problem we faced. And someone put in the chat earlier some of the problems between vertical programs, how money's spent, where health workers might want to go and spend their time for 3 days versus a month. These are some of the realities of life in terms of the problems we face. One of the ways that we did this project is to follow a, should I say, standardized prioritization process. If you wanted to read up a bit more about it, there's a little booklet. You can Google evidence-informed deliberative processes, and that was co-authored by Rob, and you can find out more details. And this is just basically a good system for tackling these difficult questions and coming up with a standard process, you could say. I'll go through some parts of these process very quickly, and then other parts we can spend a bit more time dwelling on. So most importantly, and a lot of people skip this, is to first set a good governance structure. Who is going to, one, help you do the technical things? Secondly, who is going to make the decisions, and how does it work in that sense? So what we did is we said, what is the structure going to look like? And it composed itself of the cabinets of ministers. We developed technical working groups to help do the technical stuff. And finally, the decision would go to the cabinets of ministers, including Ministry of Finance, Ministry of Health, and somewhere along the line, maybe a presidential power. Then we went through a process of selecting services. But when we say the word services or interventions, as you can think, the selection we could choose from is like the length of an elastic band. It is as long as you want it to be, and it could just go on forever. So to standardize that process, we said, okay, we will use what's known as the WHO Universal Health Coverage Compendium. And you can also look this up online. It's called WHO UHCC. And there's a tool online that they call SPEEDY, the Service Package Delivery and Implementation tool. And this can help countries, set a standardized framework and give them a list of services that they can choose to include in their health benefits package. And here you can see, if you go into the website and you sign up, you can see that this is how it's organized. It's got different areas. And then within that, it gets into more detail. It can go into cancers, mental health disorders, and you can start clicking through into different areas and getting more details. And you can even get as far as standard treatment guidelines, recommended medicines, etc. This example here takes you through to where hypertension is. So we basically took a whole lot of services and that include combining what the country currently offered and what is available in the long set of services that WHO has said these services are available. And we put all of these services into a bucket. And in that bucket, we ended up with about 424 services that the working groups and stakeholders in the country said, actually, these are relevant for our country and we would like to consider them and offer them. But these 424 services probably would cost too much. So we thought, okay, the next feasible step would be to categorize services into a high, medium, or low priority. What is most important to you and what is least important to you? And if you think about this in your daily lives, when you go into the supermarket, where do you start doing your shopping? Do you start doing it at the dessert section, or do you start at the main course section? When you're buying a car, do you start looking at Mercedes-Benz or BMWs, or do you kind of say, like, what's most important to you? So we had the set of all possible primary healthcare services, and then we decided, okay, which services are most essential to the health system, as in fundamental, can't do without. And we said, okay, these are going to be our dark green services. And there we used a categorization looking at having a very high cost effectiveness ratio, and had different sources for saying that these are fundamental. Then we went through a process working with the country to define what they thought themselves were high priority, medium priority, or a low priority. But to get to that color categorization, we had to have some sort of formula or methodology. And to do that, we started by asking the question, what criteria do you follow? What is important to you? And we just asked the question, broadly, when it comes to offering a health service, what do you find most important? And through some workshops and surveys, they came up with these different criteria. What was important to them? Obviously, clinical effectiveness, does it work? And then secondly, is there good value for money? Does the intervention show cost effectiveness? And then there were some other criteria. Does it address a life-threatening condition? Does it address where there is a high burden of disease? Other factors that were important were financial risk protection. Does it have a low budget impact on the overall health budget? And are there equitable considerations? One of the things that made it a bit easier is, fortunately, using the compendium by WHO, all of those interventions were shown or do have clinical effectiveness. So we didn't have to go around classifying everything for that, but we did have to collect information on all of the other criteria, which we then did. And I'll briefly take you through that, but we collected information on what health workers are needed for each service, how many visits are needed. So if you are doing screening for pregnancies, should a person be going in once in the 9 months? Should they be going every trimester? If there is an indication, what medication should they use? The dosage, the frequencies, should they be doing any diagnostics? If it's TB, what type of diagnostics should they be doing? And when I speak about service, when you offer a service, it's made up of many tasks or actions. And I'm sure if you are a doctor or work in the health sector, you'll understand that if a person's sick, they come through to the hospital, they might see a nurse, they might need to see a specialist, they might need to make multiple visits. They will also go off to do some labs, they'll also go off to do some x-rays, and then they'll go to the pharmacy for some medicine. So it's not just a case of a one item aspect. And that makes it a little bit more complicated later down the line, and I'll show you one or two examples of that. But we reviewed the evidence and collected data for each of the services. Again, burden of disease. What is this level of service utilization? So for example, not all people who have diabetes go and actually seek care. So what is the level of service utilization? How many people have diabetes, and what is your target population? What is the intervention cost effectiveness? This is just a brief snapshot of the data that was collected. There was a lot more behind it. What is a service? And from a medical point of view, I found this quite interesting. When it comes to diabetes, these are all the things that are involved in diabetes. So it's from the type of visit, the type of medicines. We have to take all of that into account, but I won't go into too much detail there. Then we had to do a cost calculation, taking into account all of those factors related to a task. So is it prescribing antibiotics? What goes into it? Health workers, medicines, products. How many times do they get that product? Is there a unit cost per the visit type? Who is the population in need? Who are we targeting? And finally, we come up with a cost or a budget impact per bundle. And now if you do this for every single service, the 424 services I said, all the tasks, all the actions that need to take place, you have an Excel spreadsheet that is around 40,000 lines long. So we have a big Excel sheet that's crashes computers, but it brings up amazing results to say, you know, what is the total cost of everything when you put it together? It looks a little bit it looks like a lot when you look at this cost calculation, but actually it's just all the ingredients. If you sick, what are the little bits and pieces that make up the total cost? Then we came to saying we've got a whole lot of data now. We need to move on prioritizing services and going back to our bucket. How do we color categorize these different services into high, medium, or low? So for each of these criteria we categorized the different criteria into colors, because actually it's easiest working with colors. Green is generally good, go, a good indicator. Red is maybe stop, it's not a great indicator. So for instance, if it had a good cost effectiveness ratio, we would color it green. If it had a very weak or bad cost effectiveness ratio, we would color it red. And we did this for all of the interventions. And here you can see an example where we did diagnosis of breast cancer. It made it a bit of an easier task at the end to say, actually, now that we see all of these colors, once we've categorized it, we think that it's a green intervention. And it should be a high priority because it's got high mortality, there's a high prevalence, and it covers women of a fertile age, which was one of our equity considerations. And now if you do this for all 400 interventions, you come up with some that are green, some that are orange, which are medium priority, and some that are red, which are the low priority. And if you recall earlier, I said these were the different buckets we had, and we came up with these sorts of results. 86 essential services, 182 high priority services. And now we have a little bit of a framework in terms of how we can start better allocating the resources. But then we came to, maybe I should say, the more fun or more political part of things, because it's not just about, now we have the buckets, we need to start thinking about money. And we calculated that the 424 services identified would cost $200 per capita, so $200 per person in the country, which far exceeded the budget in the country. So we said, okay, maybe we could say, how much is that prioritized list of 182 services? Well, the cost per capita is $86 per capita. So this became more of an appealing figure, but there still was the issue that it still didn't fit within the budget. We had to then consider, the Ministry of Health came back to us and said, look, we cannot change the number of health workers we have. These are staff members that are there. You can't just fire your half of your staff because you need less staff. So let's relook at the budgets, considering only the costs that exclude the HR. So we redid that and we said, okay, your 182 services that are highest priority, the cost per capita excluding HR costs is now $53 per capita. This is still too high. And they came back to us and said, well, we need to make that fit within our available budget, which happened to be $21 per capita. And we had to come up with a list of 66 services. What does this mean in terms of DALYs, your disability adjusted life years? Well, you're trying to get a bigger number in the end. If you were to do the full package of 182 services, you could avoid 10 million disability adjusted life years. If you only had $21 per capita and you implemented the 66 services, well, you can only avert 7 million DALYs. So clearly you can show here that with more money, you can get better health outcomes and you can live longer and save people that would die from avoidable diseases. So what we showed is that if we go from these 182 services, we would have to drop a bunch of services, which include diabetes, hypertension care, HIV, STIs, services that we really think are essential and should be offered. And this becomes a bit of a challenge because I'm sure you can imagine it's quite a political thing to say, oh, we're not going to offer some HIV or TB services that previously have been offered or should be offered. If I'm just getting to the crux of it, what were some of our key messages? So we worked with the government since February 2023. We looked at 424 services. The stakeholders prioritized 182 services. And they had initially said, oh, we promised these HIV services, the TB services, but they were really implicit because the government had promised services to people, and if you didn't get there within the first week, they would have potentially run out of medicines. What we did manage to do is calculate that these 182 highest priority services, they are expected to yield about $16 in benefits for every $1 in benefit spent. So there were two thoughts that I'd kind of thought about. You know, what are some of the addresses, the things that we should be doing? And actually where we got to with the country is there was a lot of push from stakeholders, and those being doctors, physicians, people who are on the technical working groups, who pushed the Ministry of Finance to start increasing the budget. Because if these are meant to be necessary services, HIV, diabetes, then Ministry of Health needs to find money to do it. And to allocate money for that. And it's been a 6-month battle, you could say, to say, how do we convince Ministry of Finance to start allocating that funding? And what we showed is, well, the government had been promising these services, but they can't fully afford it. So I think the question comes back to you, and I'll start looking at if there were some questions, but the final thoughts I wanted to leave you with, you know, what do you think will happen if governments promise services that they can't fully afford to deliver? And how can that be better managed? And if you were responsible for implementing a revised benefits package tomorrow, what would you see as the biggest challenge? You know, is it funding? Is it the public expectations? As you can see, it doesn't just come to what is the cost. That's some of the technical stuff we work with. But then there is the political aspects of what pushes you where and different stakeholders. So I'm going to pause there or break there and see if there were any questions that jumped out, or any comments or thoughts. Or maybe we can.
Well, thank you, Gavin and Rob, so much for your very enlightening and interesting talk. I think you gave a really clear key message in the importance of prioritizing the services in the benefits packages, and what happens if if the services are underfunded. And I think Gavin's example of Kyrgyzstan made it very clear, especially for me, how difficult these decisions are to make. Because I think for me, I would really, as a doctor, I think there is also a lot of emotion and feelings with it. And you are looking very clean at just the cost and benefits. So I think that's very interesting to hear and to see. And yeah, I think that's very enlightening. I saw that, and I was also surprised about that Marianne made a comment about the small increase in DALIs when going down to the level of finance in the benefit package. That's very interesting to see.
I did also see someone responded at how much is spent, I think in the Netherlands, and it's around $7,500. So you can see what the challenge is. Basically, here you're sitting in a high-income country with $7,000 to play with. And then in another country, we have, well, what we see as being the essential package of costing $200, but actually in reality, they only had, excluding HR costs, about $20. So another title we often say is hard choices. How do you make those hard choices? And how do you start to negotiate with the Ministry of Finance?
Definitely. I think there was a question from Suzanne. Do countries in similar areas, for example, the stans, work together in this? And she can imagine the budget, health impact, population type could be comparable.
Probably. I mean, we haven't really done any cross collaboration between, although I have worked in Kazakhstan and we worked in Pakistan and Kyrgyzstan. They haven't done anything together, you could say. And there probably is similarities, but that's similar to when you work in, sub-Saharan Africa. There's similarities between the regions.
And maybe to add to it is that you see that countries share information on the effectiveness of services because people are similar. Somehow bodies are similar across countries, but health systems are not. So quickly, when you go into the equity, into the cost, etc., these become quite specific to the country, and countries need to do their own evidence collection, especially do their own process. Like Gavin said, he involved technical working groups involving stakeholders in Kyrgyzstan. I think you must have involved up to 100 people sitting around different tables, giving all inputs. And that's a very necessary thing for the quality of the process, that you get a good evidence and a good experience around the table, but also for the legitimacy, because all these people who were involved in the process, they went back to the offices and they explained to their friends and their colleagues what happened. So when eventually the benefit package comes out, there's a broad understanding in Kyrgyzstan about the foundation of the package and how it was developed. So this is avoiding lots of comments and criticism afterwards. So I think we can safely say that this package is getting broad support in Kyrgyzstan because of this long, tedious, comprehensive process.
Also responding to a previous question was about healthcare infrastructure, skills that staff need. That's something we're trying to deal with now, and that's around implementation, which I'll admittedly say we have less experience with. But implementation is a huge thing to say, do staff have the right skills? And maybe also relevant for this audience, I think it's also showing that everyone has a voice. It shouldn't be health economists sitting around the table making the decision. There it really was the doctors, the physicians, the people working in hospitals and people seeing everything who sat down to, if I can say, color code different health services. And they are now the ones that are pushing and making the argument to say, actually, the Ministry of Finance needs to commit more funds to make this happen. And the experience has been, I think the Ministry of Finance is more shocked that we've managed to calculate what the cost is, because that's not been done. So if we're saying this is what it costs, $20 per person, they're kind of going, really? Do we believe this figure? And they're starting to come around and be persuaded, but it's a first, you could say. And now they can actually make decisions based on evidence. If you want to offer the service, this is what it costs.
Yeah, that's a very impressive extra help for them, I guess. They should do that a bit more often in the Netherlands as well. Or that's how I feel right now, that the politicians should base their decisions a bit more on these calculations, but not to stay with the Netherlands at all. Uh, are there any more questions? I think we have 4 more minutes of time. I will already share the feedback and evaluation link, but maybe there are more questions from the audience. I'm just looking around. I think we handled most questions in the chat. Well, if there are no more questions, I will go and share the link. Sorry, I need a small moment to do that, to do 2 things at the same time. That's always difficult.
And let me fill that time
Yeah.
by inviting people who listen in. If you like any guidance or if you like to follow up on this, please contact us. You can easily Google us, or otherwise you may have the email addresses. It's the work we do to support people, medical doctors, to get a grip on where does the money go, and to have a better understanding of what's happening at the policy level. Because these decisions have a huge impact at the facility level. Because if you see shortage of funding and material and equipment, personnel, this may well be the root cause. So
I think that's a really great offer, because I think a lot of our doctors are having these issues, to be honest, with underfunded services and things. Yeah, so I'm sure some of our colleagues will hold you up against this offer.
most welcome.
Well, I would love to thank you both very much for your lovely presentation and for your insights and sharing your experiences.